Hello, everyone. Thanks for tuning in remotely during these crazy times. My name is Dr. James Ford, and I'm going to be giving this presentation on behalf of myself and my colleagues at UC Davis Health. Today, I'm going to talk to you guys about the implementation of a high-sensitivity cardiac troponin assay and its impact on emergency department length of stay and hospital admissions. We have nothing to disclose. To give you a little bit of background on the study, as you know, chest pain is the second most common presenting ED chief complaint in the United States and represents 5% of all ED visits or 7.3 million patient encounters every year. Cardiac troponins, in conjunction with an EKG, remains the mainstay in the workup of chest pain. High sensitivity cardiac troponin, since becoming commercially available outside the United States in 2010, has been shown in multiple large multi-center European studies to be associated with a decreased ED length of stay, decreased ED admissions, and decreased stress testing. But since this has only been approved by the FDA since 2017, there's little US data available. In this study, we aim to compare ED operational metrics, troponin utilization, and cardiovascular outcomes before and after our institution's transition from conventional to high sensitivity troponin. We performed a retrospective cohort study using two time-matched 6-month study periods corresponding to before and after the implementation of a high-sensitivity cardiac troponin T assay with a corresponding chest pain algorithm modeled after the European Society of Cardiology recommendations. Our study setting was a single tertiary academic medical center, and our study population was any adult over the age of 18 years who presented to triage with the chief complaint of chest pain. Our primary outcome was emergency department length of stay, defined as the time interval from ED arrival to physical departure from the emergency department. Our secondary outcomes included hospital admissions, utilization of troponins, and acute coronary syndrome diagnoses, including STEMI, NSTEMI, and unstable angina. Our data analysis plan consisted of using a multiple linear regression model or logistic regression model for our continuous and categorical variables, respectively, and both were adjusted for age, sex, and a marker of ED crowding, referred to as the NEDOC score, which stands for the National ED Overcrowding Study Score. In this table, we see patient characteristics stratified by the pre- and post-study periods. We see the total number of patients was roughly the same between study periods, as well as the total number of chest pain visits. We see that age is very similar, and sex ratios are also very similar. And if you look at the overall ED length of stay, and again, this is all patients, so like the 33,000 in the pre-study period and the 32,000 in the post-study period, this is the overall ED length of stay. And we can see that it was about 25 minutes longer in the post-study period, which, we didn't run any statistical analyses on this because that wasn't part of our initial hypothesis, but it's worth noting for when we take into consideration our primary outcome. For our primary outcome, ED length of stay, there's an absolute difference of 10 minutes between the post and the pre-period. And while it's not shown here, using our unadjusted analysis, this difference was not statistically significant. But when we corrected for age, sex, and ED crowding using the NEDOC score, this difference became statistically significant. And since this is a continuous variable, it's reported as a linear coefficient. And since we see it's positive, we know that the post period is indeed associated with an increased ED length of stay. However, since the value is close to 0, we know that the effect is not overwhelming. And when we look at our secondary outcomes, we see that our admissions decreased between the pre and the post period, and our discharges increased. However, there was no difference in any of our cardiovascular outcomes, including STEMI, NSTEMI, unstable angina, or acute coronary syndrome. In this table, we see troponin utilization stratified by study period. It's notable that 92% of patients in the pre and the post-study periods had cardiac troponins drawn as part of their chest pain workup. The patients in the post-period were a lot more likely to have any troponin detected in their blood or having a troponin above the level of quantification. They were also a lot more likely to have, quote-unquote, a positive troponin corresponding to a value greater than the 99th percentile. One thing that's really important to mention here is that the initial protocol that we gave our providers when we implemented the new high sensitivity troponin specified that we wanted troponins drawn in 0, 1, and 3 hours. However, we see here the 1 hour troponin was actually drawn closer to 2 hours, and the 3 hour troponin was actually drawn closer to 4 hours. And in the pre-group, that 3 hour troponin was also drawn a little bit longer at 3.2 hours. But the difference is so much greater in the post period that helps explain why there was an increase in ED length of stay between our study periods. So, in conclusion, while our unadjusted analysis did not find any difference between ED length of stay between study periods, our adjusted analysis, which corrected for age, sex, and ED crowding, did find a small increase in ED length of stay in the high sensitivity cardiac troponin group. However, we also found that the high sensitivity troponins were associated with a decrease in ED admissions and no change in acute coronary syndrome diagnoses. One thing that's important to mention is that it's difficult to separate the impact of the new assay from its accompanying algorithm. And so we knew this going into the study, but we felt like it would have been unethical to not provide our providers with the most up-to-date evidence, given that the European Society of Cardiology had already published guidelines on the use of this new assay. And one thing that we do expect in the future is that when there is an increase in provider compliance with respect to the timing of the serial troponin draws, we expect our ED length of stay to decrease. Since this is one of the only studies coming out of the US so far with regards to high sensitivity troponin, further studies are needed to evaluate other outcomes and other ED metrics. Here's a quick list of my references, and I'd just like to end by thanking everybody who's out there on the front lines taking care of the COVID-19 patients, and may you stay safe and have a great rest of your year.